This program is brought to you by Emory University.
Well, it's my great pleasure to introduce Carlo Cecco to speak to us on an area of his expertise. Carlo is the head of our cardiothoracic imaging division here at Emory and is a professor of medicine, radiology. And he has extensive publications. He runs a funded laboratory looking at artificial intelligence in radiology. He is extensively published. He's part of many different boards across really the world. And we're really lucky to have him here and have him today to speak on the state of artificial intelligence in cardiac imaging. So I'm looking forward to this talk, and thank you, Dr. Cecco, for willing to speak to us today.
Well, thank you very much for the nice introduction, Christina. Thank you for the invitation, and good morning, everyone. Today, we're going to talk about what is the actual state of artificial intelligence in cardiac imaging. These are my disclosures. So where are we right now and where are we going? You know, over the past few years, there have been many predictions in artificial intelligence in general. We went from, 2015, Elon Musk, self-driving cars in 2 years. We are still here, and I'm just start seeing these cars. We have been in 2016, Jeffrey Hinton, radiologist obsolete in 5 years. And in 2025, here we are. We are still driving our cars to work. So it's very the lesson is that it's quite difficult to make prediction, especially about the future. So I'm not going to make a fool of myself giving you any prediction on where we will be going. I'm going to show you what is actually the state of the AI and probably what could be some future application. So why I'm showing you all these industry, I'm not getting any funded by any of them, but this is to tell you that, as you already know, AI is everywhere. We are using AI in every app every day for every application we are basically doing on internet. We are having AI exposures. And also the same is in the medical field, especially in the imaging. Almost every vendor that we are using, that we have at Emory in our scanner, in the background for the analysis, in our PACS or in Epics, is now using AI. So we are already embedded in an AI world, and that's why I like very much the definition that Andrew Ng, the founder of Coursera and a Stanford professor, gave about AI, that is the new electricity, and is going to power up a lot of new application and possibilities for us. But to get a better understanding why it's so pervasive and why AI is going to be so critical for our development, I guess we need to look also at the numbers. In particular, the numbers of the investment in the artificial intelligence in the healthcare market. In this case, as you can see, this is a prediction that the US AI market will move from barely 4 billion in 2020 to almost 50 billion by 2026 and growing, with a compound growth rate of approximately 37% per year. So as you can see, as you already know, the money that have been, poured in this in AI development is a lot. It's been quite huge, and this is why there's been such a fast and rapid growth in the field. And this market, the artificial intelligence application for medical imaging are also quite extensive, are receiving a quite extensive amount of this funding. We have, of course, many more fields like, robot-assisted surgery, fraud detection, dosage, virtual nursing, but definitely imaging is a very important part of this, receiving a significant amount of these funds. And if we're going to look at the AI market, in particular, all the FDA-approved software or devices this was 1 year ago, but the data are barely changing in these 6 months. The vast majority of AI application have been in radiology and in the cardiovascular science. So in this case, we are almost 90% of the entire application. of all the new developed and FDA approved devices. Let's take a step back. So what does it mean AI? AI, of course, means not artificial intelligence, but I prefer to use the term augmented intelligence. And this term has not been, proposed by me, but has been proposed by the American Medical Association actually in 2018. So the use of AI to augment physician or combining all the artificial intelligence technique system to improve our daily work without replacing us. And I think this is something very important also to clarify when we start talking about AI, that we are not trying to replace ourselves, we are trying to augment our capabilities and to enhance our performance. And we need that because this is, an example of our standard reading practice. This is one of our fellow reading cardiac imaging. The field has changed very little since when I started doing cardiac imaging in 2005. In the last 20 years, we are still, looking at our images, doing measurements, and drafting our report, which is, of course, standard practice. But we are, on one side, the volume has been growing exponentially. On the other side, we know right now that we are missing so many quantitative information in our daily report, which is also prone to mistakes. So we really want to have some help to improve the quality of our, reporting and to give us more quantification, more quantitative data to evaluate, to assess our patients. And also to give you another example why we need AI is because, by 2020, our general medical data are doubling every 2 months. So the data we are producing in our system every 2 months, they are doubling. The CT and MRI examination has increased approximately 30%. And for the radiologists, but in this case, all the cardiac images have been increasing only by 5%. And this amount actually for cardiac imaging is even lower. So in this case, we have a big unmatched demand or between the number of growing study and our capability to read them. That's why we need to do something. Also, to give you some more number, the studies are becoming much more complex. We are moving from few hundred images per studies to thousands and thousands of images per study. If you think that, for example, we moved from for a standard cardiac CT done in 10 years ago to one, or actually right now as well, to approximately 1 gigabyte. Right now, the new cardiac CT done with a photon counting CT, the size is about 10 gigabyte, which is a much larger amount of data to post-process, to analyze, and to where we are, of course, where we can get extract additional information. There is a burnout. We know that this number is old and is actually probably also underestimating the real entity of the phenomenon. But and this is applied to everyone in healthcare. We are burnout. Our number of studies is growing, and we have to read more and more and faster. And there are 40 million of annual diagnostic errors worldwide. So if you think that we're using AI application, we can reduce this number and maybe bring down the number of mistakes that are done, this would be, of course, huge, especially for the impact we can have on a global scale. And also, to give perspective, the demand for cardiac imaging is growing. This was a recent study showing the trend for cardiac CT. These are nuclear imaging, and this is the yellow one is cardiac MRI. Cardiac CT usage is exploding, and we have seen them. We have a lot of guidelines recommending now as a class 1A indication for patients with stable coronary disease, for structural heart disease, for planning, for congenital. So this number is definitely growing up, and also the cardiac MR number are, even if slower, are definitely increasing. We know the importance of cardiac imaging for myocardial characterization. And this is also the reason we not only have, class 1A indication, we have now FFR-CT that has been since 2021 in the AHA-ACC guidelines. We have now plaque burden and plaque analysis, which has been, in the guidelines since 2022. And we have just got recently a CPT code, and probably we're getting reimbursement in the future. So we are getting more and more toward the usage and the quantification of coronary disease with our imaging. And again, this is getting also Medicare coverage. What is actually, again, this is just a small snapshot of all the of some of the available FDA-approved AI software. They are a lot, doing a lot of different things, from X-ray to EKG analysis to cardiac CT. And again, this is just a number of a small number of all the right now industry involved in developing this software. The vast majority of these, the truth is that will get busted probably because there is not enough utilization. But among these one, we will have few champions. We already have some champions that are, taking the lead and probably will get deeply embedded in our practice, in our healthcare practice. And so when we come to cardiovascular imaging, we already have several societies that are, coming out with scientific statement on how to use artificial intelligence, what are the application, and the application are quite broad, going from, patient selection for the best test for the best patient to acquisition and protocoling. Analysis, so improving again the detection of coronary artery disease, lead enhancement, quantification, and finally to what I call the holy grail of cardiac imaging, that is, and in general of our practice, that is the outcome prediction. So being able to extract meaningful results from these studies, combining them with clinical information to give the best prediction to our patient and also the best treatment. Just a very general overview of what we mean with artificial intelligence. Artificial intelligence is a sandbox term where there are very different subset of application. When we talk about artificial intelligence applied to cardiac imaging and to healthcare more in general, we are talking about machine learning and more specifically of deep learning. What are these applications? The deep learning are software algorithm based on deep neural network, which are network where we have, an input layer where we put our data. Hidden layers that perform the analysis have been trained and perform the analysis, and these hidden layer can go from a few hundred to millions of hidden layers. And you should think of each one of a relay, a neuron that is going to analyze a specific part of the image, like for example the shade of gray, the pixel, the color, the kinetic, whatever, and they are going to come with a pathway or to make a prediction. And this prediction can be about everything, about the size of the heart, about the outcome. But what is more important is that this is a black box. So we really don't know right now how the algorithm come up with a certain answer. We know that is right. Actually, this is not completely true. We have a certain understanding, but the reason is that it's very difficult, especially for the more complex application, to understand why there was a specific result. And that's also something important where, there are work going on to open the black box and to, make this more clear. And together we have, more application that is going to be based also on a characteristic of this one, like the neural network development, the autodidactic quality, so how to this network can self-train themselves and go and on and on. So as we already mentioned, what are the applications in our daily practice? There are, in a nutshell, these are the major applications. Mainly, we're going to focus on the, let's say, image acquisition, image analysis, and prognosis. Study protocol, there are already several studies, and there are research going on automatize all the protocoling. So having, in this case, based on the clinical indication and on the patient clinical history, so on EPIC and all the possible information to select the best protocol to improve, again, to reduce our error rate and to standardize our acquisition. There are studies working on, for example, acquisition and scanning. For example, many scanners are coming these days, or they can come with the option of a 3D camera positioned on the top of the scanner. This camera can automatically, create a 3D reconstruction of the patients and then performing, analysis to automatically center the patient in our grant. And based on this, you can, of course, based on an accurate reconstruction of the 3D body of the patient, you can, select the best radiation dose, or without going too high or too low with the radiation. You can think to combine this one, for example, with contrast injection based on the patient size and volume. So there is a lot of research going on also on these things, ultimately, to have excellent image quality regardless of the condition, and also of the capability, let's say, of the acquisition text, because there are centers where maybe they're not trained specifically in cardiac imaging, but still they need to do or start doing some in a while cardiac imaging. They want to have this one. They also have, there is the possibility these days for the industry to that are selling the scanner to remotely log in the scanner and run the scanner if there is some difficulties or some problems. So right now this is going forward and it's becoming more and more automated, or with a large possibility for development. But if we go on to what is the core of what we are talking about, it is data analysis. So what are the data that we can extract, for example, from a coronary CTA? This is, a summary of the major, of the most general data. We can go from, calcium score, automated coronary analysis and quantification, plaque vulnerability features, which are very difficult to detect, and definitely we could get help from better software. Fractional flow reserve is moving from the fractional flow dynamics. There are options to do this with AI. Radiomics, so the evaluation of all those characteristic, pixel characteristic that can help us to early detect disease. Finally, going again to function, volumes, and prognostication. And if you think about the number of information that we could extract, for example, from a coronary analysis, you know that are a lot of numbers that right now, these days, we are still not providing in our reports, because it's difficult, because it's time consuming, because it's we don't really know what is the clinical impact of many of these data. But definitely right now we are focused on the plaque stenosis, and we are on the degree of stenosis, and we are moving to the plaque burden, providing a quantification of the plaque. But we know that, the plaque composition, a granular plaque composition assessment possible with photon counting, the plaque morphology, the direction, the length, the bifurcation, these are all important information that we could catch and also provide with our new software. And we can go forward. I mean, not only the plaque, but also the epicardial fat. What is the situation of the fat surrounding the coronaries? We can quantify those fat. I'm going to show you, and also do radiomics. We can look at the functional assessment, both with FFR, with shear stress. We can look at CT perfusion. We have been doing some for research, and actually it's a very interesting technique to both look at the myocardial status and the concomitant coronary artery disease. And again, as I mentioned, the target of coronary atherosclerotic imaging are much more than we are providing, because right now CT can provide, as you can see, a lot of information going also on the characterization of the plaque, and in case predict also the risk of plaque rupture using new software and new algorithm. And this is some of the study. This is a study done with photon counting, showing in this case how it's possible to better characterize in this case the plaque in comparison with histology, OCT, and IVUS. Cardiac CT, coronary CT is not the only application. Cardiac MR has benefited a lot from artificial intelligence. In particular, this is probably one of the best clinical application we had, which is quite simple, is the volume analysis. Before AI, we were drawing our circle manually. This could take time, complex cases, congenital patients. This congenital patient is still difficult, as Christina knows, because the software is not optimized. But anyway, for this was taking a lot of time doing this analysis. And right now, with our artificial intelligence, we can take a quite good assessment in just few seconds. And this is what was one of the first studies assessing this, showing also that the other benefit is that when we use AI, the time goes down significantly. You have, few seconds compared with 15 minutes approximately, but also there is no inter-observer or intra-observer variation. So the scanner is providing the same amount of data. And if this analysis is still, sometimes we need to make adjustment for the right ventricle, and things is becoming better and better. So probably with the growing number of, with the retraining of this algorithm, these results will get even much better for right ventricle, for congenital, for any complex study. We have not only imaging, I mean, the heart is, of course, in the chest. So think about all those data that we are missing or we are not capturing from a cardiac CT outside the heart. There are solutions doing all this kind of analysis. For example, this is one of the software we have been testing and publishing is the Red Companion from Siemens that is providing automatically, evaluation of the aorta with measurements, evaluation of the lung nodules, evaluation of the spine for fracture, emphysema quantification to see what is the volume of emphysema, or also calcium score evaluation from non-coronary studies, which are another important area where we can get, again, very important results. But obviously the core of this analysis is the AI applied to coronary. This is the AI Art, is an experimental Siemens software we've been testing for the past few years, showing that the software is able to, in few seconds, to provide, of course, the calcium score, which right now is clinical routine, but also coronary evaluation, providing a segmental assessment of the coronary stenosis and providing you the degree of stenosis for each coronary segment, together with the cataracts and the overall assessment. And this is quite interesting because, as you can see, the software provides you for each segment the amount of stenosis and also the presence of calcified, the composition, if the plaque is calcified, non-calcified, and mixed. And in the future, they will also come with evaluation of the vulnerability features like napkin ring sign, spotty calcification, hypodensity, and positive remodeling. And we have been, this was one of the first paper published using this software where we were showing that the application of these analysis, speed up the reporting time, but also most importantly, significantly reduce, in this case, improve the reader agreement, in particular for non-experienced readers, which is quite important considering that with the increased amount of studies we need in the now and in the next future, more cardiac imagers reading. So definitely we need to have people that can be trained quickly, but definitely we can provide with this software, also probably improving the agreement base, even if these people are not very experienced in reading that or just started. So this was aimed for resident or fellows. If we apply this one to moving forward from the stenosis detection to the plaque burden, we know from recent data, this was one of the first studies published showing that the plaque burden is definitely able to predict the future cardiovascular event. This study was done on the data from the Scott Hart trial, one of the largest cardiac CT registry. Scottish registry for the evaluation of coronary CT and prediction, showing that, for example, they were able to identify a threshold for the plaque volume. So if the patient had more than 238 cubic millimeter of plaque volume, the risk of having a cardiovascular event was incremental compared with patients with lower burden. And in this case, not only about the plaque volume, but also the attenuation. So low attenuated plaque burden was highly correlating with the presence of future heart attack. So plaque burden prediction is also the next step. And many studies, came on the top of this, doing additional analysis. This is the result from the Emerald 2 study, where they were combining not only the plaque burden, but also plaque additional information about the FFR-CT, the shear stress volume, showing that all this combined information were having were better predictors of in identifying the culprit lesion and risk of cardiac attack in the future. This is another study, the Advanced Registry in 2024 from HeartFlow, showing that, again, when we are quantifying the plaque and combining this data, so this quantitative coronary evaluation, you can see how they are, here quantifying the calcified plaque, the soft plaque for the entirety of the lumen. And when they are combining this data with FFR, again, this was having a better prediction of future cardiac event compared with just with the stenosis alone or the plaque volume alone without FFR. And based on that, right now we have many players in the field. We have HeartFlow that is offering this solution. We have clearly that you may know, founded by James Mean. We have Elucid, we have Siemens Healthineers, and we have many more. These are just probably the four majors. And there are other trials that are just started. We have the HeartFlow trial. We have the Clearly trial with the Confirm2 registry where we are participating, and we have the Elucid trial, where I am one of the PI with where we are doing the same with the Preview registry for the evaluation of the impact of plaque burden. These are all global registry, and the main aim is to identify, of course, the impact of the plaque burden, the risk prediction, but also identifying the real threshold, like we did for the calcium score in the past. So what are the plaque burden categories where patients need to be treated more aggressively, less aggressively, not treated at all? And so going on, this is showing you some of the studies we have been doing here. For example, we started doing with the Lucid. We applied the Lucid to the SCORE trial. As you know, the SCORE trial is being a long-going trial at Emory, were aimed to assess the plaque burden in a female African American with HIV. And in the study that was done, we were assessing the presence of the plaque burden at the baseline, and after a 3 years follow-up, showing that there was an increase of calcified plaque. There is, the trial with Clearly, where they're doing pretty much the same. So measuring, in this case, the progression of plaque in the general population, but also in a specific population like patients that are going to the new, PCSK inhibitor, showing, for example, plaque regression after, this is a study done after 18 months, showing the baseline and then plaque regression. The same, again, I show you with Siemens, that we are one of the few centers right now testing this software that is providing the same information with plaque burden, plaque, soft plaque, and calcified plaque amount. And these are some of the results that we have been, analyzing. Some of the patients we have been analyzing, showing, how we do the analysis and the progression or the regression of the plaque. This is another paper we just published, came out this month, about in a much larger population, where we evaluated on 622 patients the application of the software for the again the reader the time of reading and the inter-reader agreement between reader with the same expertise, and also in combination, in correlation with our own report, so with the clinical report, doing also a second session for in case of disagreement, where there was a disagreement between the two human reader. And the results were very interesting, again, showing that this fully automated algorithm can improve the disease detection and stenosis classification, especially in those cases like CADRAS-2, CADRAS-3, which are, the moderate, the mild to moderate stenosis going from 30 to 70%, where there is a higher grade of incertitude due to the intrinsic limitation of our scanner, like spatial resolution. This is another study where we have been analyzing. It is a study led by Patel at Emory on the association of the androgen deprivation therapy in a patient with prostate cancer to evaluate the plaque progression or regression. And in this case, we have been analyzing the plaque, showing that after treatment there was an increase in these patients in the patients under treatment with the androgen deprivation therapy of the calcified atherosclerotic plaques. So there are, in a summary, a lot of field where we can right now apply the plaque burden quantification. Going on also, this is another study we are doing in collaboration with Siemens, where we are comparing and trying to refine and improve their AI algorithm in combination with IBUS. So collecting patients that are going to cardiac CT and to IBUS. Right now we are tracing and the plaque burden with the IBUS and comparing these numbers with the plaque burden we can trace with the cardiac CT. This is a study done in collaboration. The other US center is Stanford, and right now we have almost reached 80 patients for the Emory side. Which is very interesting because, of course, there are very few studies out there directly assessing this software in combination with, direct with gold standard, like, for example, IBUS. As I mentioned, plaque burden is just one part, because we can go on and integrate FFR. We have also the research, the Siemens research software for the FFR analysis. So in these patients, we can combine plaque burden, FFR analysis, and also we have been doing a study that just over the match registry, where we were scanning. We scanned 20 patients that got a cardiac PET CT, and we scan after the cardiac PET CT. They got a dynamic stress cardiac CT, where we were analyzing the plaque burden, the FFR, and the perfusion, the myocardial perfusion, a quantitative evaluation of the perfusion, in using PET as the gold standard, trying to do a comprehensive cardiac evaluation, getting information both from the myocardium, the flow, and the morphological assessment of the plaque. Of course, there are many challenges to this plaque analysis done with AI software, which are, sometimes this number don't match. You see the analysis performed by the software, and this software still need training. They still need manual adjustment. So we cannot just get the image directly from the software, because they can be off. And especially for when the image quality is not excellent, all the person doing cardiac imaging knows how difficult it is to assess a plaque, all those very nice features that we were mentioning before, and quantify in patients with less than optimal studies. If we have motion artifacts, if we have blurring, obese patients with quantum mottling and increased noise, all these things make the analysis more challenging. And that's why we need more and more assessment, larger number of patients to train our algorithm to make this assessment reliable and reproducible. This is another example. For example, the software was telling us that was a lipid-rich necrotic core on the left main and the LAD. At the visual assessment, there was no lesion detected. So this software can be off. Also, there are other problems. Right now, we need standardization. As I showed you, there are many vendors doing this analysis. We still don't know how these vendors compare. There was just a study that came out recently analyzing, comparing these vendors, showing that there are differences. And that's understandable because the algorithm underlying the analysis is different from all these vendors, and we don't really know how these algorithms are working in the black box domain. So in this case, we need a consensus. We need to start to, standardize the measurements and the quantification. We need to measure, apple to apple. These are all the parameters where we need to work, in a society level and also at a vendor level. And also keep in mind that we need to standardize our acquisition, because we know very well, as I mentioned briefly, that if there are changes in the acquisition parameter or in the reconstruction parameters, the quantification change. We know, for example, that if you reduce the tube current or the voltage, we have an increase in the beam hardening of our plaque, and so we are overestimating calcified plaque, for example. If there are pacemaker leads or the intracardiac device, the quantification is also off. So there is a lot of work that needs to be done, to standardize these measurements, to be sure that we are measuring with all these vendors apple to apple, and also to come up with numbers that make sense for our clinical application. This is a very nice study that was done with Clearly by the group of James Mean, showing that, for example, they were trying to come up with a quantitative evaluation of the plaque burden, of course, like we are doing with calcium score, to identify what is the threshold for a negative study, what is the threshold for a low plaque burden, a medium plaque burden, and a high plaque burden, and see how these plaque burden are, of course, impacting outcome like calcium score did. So it is a very exciting phase, because right now we are, doing all the studies, trying to understand what the plaque burden means, what means the different plaque burden for calcified, non-calcified, and how the criteria, the additional modifiers like soft plaque or vulnerable plaque can change these things. Just a snapshot on how photon counting is going to build up on these AI analysis for coronary. As you know, photon counting is right now the gold standard for coronary evaluation due to the increased spatial resolution, 0.2 millimeters in comparison with our 0.4. So we are halving the size of our voxel. And this can really help in improving the detection on every one of these characteristics, in particular the presence, the characterizing, the plaque composition other than the degree of stenosis, and identifying, as I mentioned, those vulnerability features which are important but are extremely difficult to identify in the clinical practice if the study is not of an excellent quality, likely, the Knapp-King ring sign, the spotty calcification, or the low attenuation. And we know from early studies on photon counting that this is the study with photon counting, and this is a study with a force, with again the top non-photon counting scanner, showing how the delineation and the definition of the plaque is much better. So we can see much better the plaque. We can identify fibrous cap. For example, this was a very nice study doing a comparison with OCT for the evaluation of the plaque component. We can identify spotty calcification. So, and also this is going on the benefit. For example, stent evaluation with photon counting is much better, and we can evaluate very well all the stents. So definitely we are hopefully getting this technology this year, next year here at Emory. So this will definitely improve our capability to look at this plaque and our research. There are very nice initiative to use AI, creating, a roadmap for identification of the vulnerable plaque. So in this case, this was a very nice paper came up trying to summarize all the actual evidence going from, as I told you, from the AI application for coronaries, but also, to a PET application for the assessment, again, of vulnerable plaque, trying to create what is the best imaging pathway and trying to summarize all this information using algorithm for the plaque evaluation. Moving forward to radiomics, as you know, radiomics is that part of the radiology where we are trying, or imaging analysis, we are trying to analyze the pixel component. And there is some very nice things because we are able, to come up with a kind of genomic-like heat map for the plaque composition. And we know from these studies that this can differentiate from vulnerable plaque to non-vulnerable plaque, soft plaque from no soft plaque. And there are, again, a lot of AI application and studies going on this one, trying to train algorithms to identify these radiomics-based features, showing that it's possible in this case to predict, again, the vulnerable plaque from non-vulnerable plaque, so the culprit lesion, using this software. And moreover, one of the group that did the most on radiomics is the group of the Oikonomo in UK, showing that they were able to apply this radiomic signature to training an algorithm able to identify them. And they did this one coming up with all these assessment of the pericoronary fat, showing that this was very well correlating, this map, with the histological biological correlates after biopsy, so of inflammation, fibrosis, and vascularity. And using this algorithm, they were able to create a pericoronary fat radiomics profile predicting the increased risk in these patients for bad outcome from MACE. So there is a lot going on. A lot can be done also on the pericoronary fat. CT-FFR, I'm not going along on this. We already mentioned, you already know that the gold standard for FFR and the only FDA approved right now in the US is our flow, and based on the flow hemodynamic calculation. But right now there are many software that are offering, research application, but also not only research, because in other countries are actually utilized for the machine learning based FFR. So we have this option, we can do this. And there was result from the big study we did in 2018, the machine consortium, that was a large consortium comparing CT-FFR with Rflow, showing that the machine learning with the Rflow model, showing that the results were very much matching. So machine learning can provide also FFR evaluation, and there are more software going in this. Finally, moving to the final part, I mean, the prediction is probably the most important, one of the most interesting part. This was a beautiful study, came up one of the earlier in 2020, where they train an algorithm based on all these imaging variables and also clinical variables, imaging variables derived from calcium score, showing that when they were analyzing first of all, on this algorithm, the weight of any single variable, the imaging features were trumping the clinical features. And that makes sense because, of course, one thing is knowing that the patient is diabetic or have family risk. One thing is knowing that there are real calcification in the coronaries. But the most interesting result was that when they train an algorithm for the outcome prediction, the machine learning algorithm was outperforming all the other existing prediction algorithm based on the clinical only or imaging only. So in the nutshell, if we are able to create or to train this algorithm not only on the clinical data or the imaging data, but combining all this data we can extract, we have much better prediction for our patients. And that's what we have been trying to do, to work on in one of our grants in the past few years, trying to extract data from the imaging and combine this data in a fusion model with clinical data to predict our outcome. And that's why we have been creating the Emory Cardiac CT registry, where we collected all the studies done in the past, more than past 10 years at Emory, both cardiac CT and calcium score, to try to analyze this data. And right now we have approximately 20,000 cardiac CT and 40,000 calcium score. This is a very important registry also because, as you can imagine, at Emory in the Atlanta region, this is one of the very few registry with a very wide ethnicity representation. Many registries, especially, are coming from the Northeast, are biased with a preponderance of white population. Our registry is one of the few with a very important number of non-white ethnicities, so African American, Asian, Latin American, which are making this result very valuable for analysis. And this, I mean, again, we can try to integrate these AI analysis in the pipeline for triaging. This is something we were, trying to or exploring for acute patient. We can go on and move not only horizontally but vertically. So think about vertical integration not only with our imaging features that we can extract, but all the features from the patient, going from genomics to proteomics to again clinical phenotype. And this is a very interesting and exciting area of research. And finally, we can arrive to the so-called digital twin. And this is something we did in collaboration with Siemens a few times ago, and it's very interesting. I mean, it's possible these days to create a virtual avatar of the heart, starting from the images, placing on these images all other characteristics from the electrical modeling of the heart, and creating a virtual heart where you can manipulate and you can test. For example, there are studies showing where in this heart you can change the parameters from, for example, from sodium, potassium, and see if it's going to create arrhythmias in this model, or you can see how the heart is going to respond after therapy if you're going to ablate at a specific point. So this is very exciting. Is really the next part of what we are doing, the next frontier of all these data. And I'm going to conclude. Of course, there are many challenges of all these clinical application. The main challenges are the data accessibility, training, and reproducibility. We need to be sure that these algorithms are well trained, on a heterogeneous population that can so capture all the nuance and the variance in the clinical, in the real world. We need to be sure that there are no biases in this algorithm that can skew our analysis. There are barriers. We did a quite deep analysis of all the barriers for the Latin American Development Bank a few years ago, showing that the main barriers right now are infrastructure. So we need to build up infrastructure for all the need of AI, and that's what's going on with all these data centers that are creating right now. Regulation, funding and reimbursement. These softwares are not coming for free. The vendors are not developing this software for us for free. So also finding ways to reimburse if there are no CPT code or other way to reimbursing needs to, we need to figure out how to pay per this, and if it makes sense to integrate this software in our clinical practice, paying additional money for those software, going to training for us and for the patients and data protection. In summary, artificial intelligence is playing a significant role in cardiac imaging. We can identify new features, we can identify new biomarkers. More importantly, we can probably, and that's going to be the next step, is definitely improving our workflow optimization. That's what we need. We need to get faster, better, providing more quantitative data and extracting more information from our scan. This algorithm can help with the extraction of data and integration with clinical data, providing a superior and a better cardiovascular risk prediction. And finally, the final purpose is to improve the amount and of data, the number of data, the quality of data that we are providing, to the clinician, to the healthcare system, to better treat the patients, changing finally, of course, the outcome of our patients. So, and in summary, I like to conclude saying that there are many challenges in AI. There are many things that even if there is a lot of hype right now, we don't know many things. We are just researching, and we hope to bring them to the clinical practice. But it's definitely a sector right now, a possible revolution that hold a lot of hope to improve our clinical practice, to improve and to change our daily practice, and in general to improve and to expand the access to all our advanced application to the general population, and improving in this case the health equity. And with this, when I'm done, I want to thank my lab, my associate, Dr. Vanassen, and all the lab people for the research and many of the data I showed you today. And I thank you for the attention. And I guess we have time for some questions. Yeah.
Well, thank you, Carlo. That was an amazing talk and amazing summary of kind of where we are and a lot of different new things for the future. One question I have just from an education standpoint is how is this affecting, at least within the radiology world, how you're having to change how you're training, since this is such a rapidly evolving field of like, how do we prepare the workforce for the future and then get everyone else that's already trained where we need
That's
to be for this?
yeah, that's a great question. There is a lot of things going on. It is before we, as you know, we are already using some AI software, for example, for PE detection in all our scanner when they're done. At the beginning, we were debating if we had to, for example, to give resident access to this software in order for training purpose. At the end, we decided to give them, and this software actually can be helpful because can help the resident, the training people to get better in the meaning that they are showing you maybe some PE that even for training radiologists can be difficult to pick up sometimes. But of course, there is all the other side that there is a big risk of detraining that is coming with this software. There was just a very recent study published that I couldn't put here, that there is a study done on colonoscopy, showing that after a few months of using new AI tools for polyps detection during a normal colonoscopy, after they were removing the AI tool, there was a reduction in the sensitivity of the physician in detecting polyps, which is very concerning. And actually, I feel that myself because, for example, we have the AI doc, this PE study at Emory. We don't have that at Grady. When I'm used to have that at Emory as a safe backup and I'm Grady, sometimes I need to force myself to remind that I don't have the software backing me up in that case. And I can see this risk. There is a lot of discussion going on how this detraining is going to impact us. So it's very difficult to find, an answer or one size fit all because we are still understanding how these things are impacting out, but is a real risk. And I think that one thing is we need to get exposed. So these things are there. We need to expose our trainees to this reality. At the same time, we need to make sure that they're not missing, training opportunity or not losing skills using this software.
We have a question in the chat from Dr. Memo. Thanks for the presentation. The AI generated CAD-RAS system by Siemens, is it under investigation or is it currently clinically applicable?
Is under investigation. It's still not a clinical product, but they are aiming to make that a clinical product probably next year, 2026, I guess.
Is it available in other parts of the world already for clinical application and the US is lagging, or is it
not
under investigation everywhere?
No, I mean, is in Europe, I guess, has been already validated, but to my knowledge, the center using that or doing research are very few these days. So I'm not sure that is a real available option. But I mean, it's not the only one software. For example, we already have the results from the RFlow that, as you know, we are using as Emory RFlow for FFR, and RFlow also provide you with, let's say, a quick result showing the degree of stenosis that is based on AI as well. So it's not the only software out there doing this analysis. We are in some extent already using this software. The thing is that this software are not 100% accurate. Actually, they are much less than 100% accurate many times. And this is a lot based on the quality of the study. So it's very easy for a software analyze a perfect study with no motion artifacts, with nothing. But that's very easy for everyone. The expertise come up when you have to analyze software that are not excellent, and that's actually the vast majority because patients come with variable heart rate, with sick patients moving, whatever. So in this case, that's where we need thanks God, clinical expertise. We are still needed for that, and I don't think that's going to change anytime soon because training those algorithms for this data still takes time. So still we have some role.
Yes, I feel like we still have plenty of job security.
Yeah.
Another question from the chat is, do you think the AI tools will be able to integrate echo findings with cardiac MRI and CT for a better overall picture of patients in terms of across cardiac imaging modalities?
Yeah, that's a very interesting feeling, meaning that I didn't show, but there is also a lot going on echocardiography. So there are, as you know, there are many software doing automated evaluation, quantification, analysis. I guess one field where there is still a lot of research need to be done is multimodality integration, because we have patients coming with coronary CTA, with, cardiac MR, with echo, with PET. Would be beautiful having software where we can, overlay, integrate your, for example, your coronaries from the cardiac CT to your cardiac MR map to see where the infarct it is, for example, what
Mhm.
second, what. And again, if you think with the photon counting, we can go much more granular in the evaluation of small vessel, of branches, of diagonal or marginal. There's a lot that can be done. Integrating those data with PET, so with again with metabolism and things. So yeah, it's a very interesting field. There is research done, but not that much to my knowledge. So definitely it's a very exciting field to go on.
Has there been a lot of overlap that you've seen between the different areas of AI across the radiology? Like, it seems like cardiac is a huge area, probably because of the financial ramifications within the cardiac space. But will this then roll over into other areas of chest division or across that in terms of what we've learned in cardiac that can be expanded out?
Yeah, no, we are testing many software for chess city as well. We have a committee, an AI committee, because as you can imagine, it's very difficult to decide which software is the best software to buy, to integrate with all these offers. We are testing right now lung nodule software for chest X-ray, for chest CT. We have software, evaluating software for in case aortic evaluation, PE. The problem is that many of these software are good, but not good enough, to help really us. Because I give you an example. For lung nodule software in chest CT, if I have a software that pick up the nodules but doesn't do a perfect job and there is missing out some nodules, in any case, I still have to go there and look at the study and at each nodules one by one, which is gonna just slow me for the evaluation. So the clinical implication, I mean, it's much more difficult to demonstrate the utility or the integration in the workflow. That's right now where we are still, where there are still challenges in that. And for studies like cardiac MR, where you are saving, for example, 15, 20 minutes, for the volume analysis, the needs is definitely striking. But for studies where you are saving maybe 30 seconds or 1 minute is really, and you are paying a lot of money, is still debatable. I guess
Yeah.
as a question. Yeah.
There's another question with photon counting, coronary CT, who's going to be doing these studies and when will invasive cath disappear?
I mean, I don't think invasive cat is disappear. What do you mean? Who is going to do this study?
I'm not sure. It was from Dr. King.
I mean,
Yeah,
all
I
the
think,
imagery and yeah.
yeah. So, hey, Carlo, great talk. This is Patrick here. I to Spencer, to answer your question, the photon counting CT is going to go in at Clifton. We're hoping, spring of 2026. But Carlo, I wanted to ask you. You talked about obviously a lot of the potential here and some of the you know I guess current limitations, even with the kind of most far along use of this in cardiac imaging with heart flow, we still see lots of errors, right? And that sort of study quality and maybe the highly selected studies that go into the research, publication aren't quite what we see, and so we have a lot of difference there. How far do you think we are from a lot of these applications actually having the accuracy and reliability that we would expect? Because I think even with heart flow, I think we've learned over the last year or two while we've used it that there's lots of limitations, right, to the data and to its AI analysis and things that give us some pause in using it. So what's your impression about how far we are from these things being as reliable as we want?
Well, as I said at the beginning of the talk, I'm not gonna make prediction to not make a fool of myself, but my feeling, and I guess take that with a grain of salt, is that we came a long way in the meaning that image quality, which is probably one the most important predictor of a good study and of our clinical ability, has greatly increased over the past few years with the new AI reconstruction. If you think about what we can do with our Siemens, with our G scanner, with snapshot, with reconstruction, we see studies that before were almost non-diagnostic, where right now with this reconstruction are diagnostic, are much better. And that was already a huge, improvement. And I think with this software, taking out the hype from all these vendors that, of course, want to sell their products, definitely FFR in selected cases helps a lot. And I don't think FFR is going to be, the major player because we cannot expand FFR to every patient just to select it. But this software that are helping us in doing a quick diagnosis, in reading a coronary CTA or telling us immediately if there are severe stenosis, or for the plaque burden, which is a very exciting because there is a lot of promising in quantifying the plaque. I mean, the growth has been quite quick in the past few years. So I think that we will start using this software for stenosis detection and quantification much more in the next few years. And I really hope that plaque burden will be, after these big studies will produce results where, get integrated in the guidelines as something that is needed for every patient, like we are doing for calcium score today. So I assume, if I have to give you a timeline, that in the next 5 years, we will see definitely this software getting more and more in our practice and helping us, at least in some extent.
Carlo, Stan Sherman. For those of us who have to take care of patients, what are, we used to have to send off, studies for FFR. Where are we doing them locally now to get FFR for our invasive cardiologists who, really like to go by that in terms of, some of the invasive work that they do, and what is generally available for us, I guess, is what we're saying. I know we used to send off the FFR. So what can we do here at Emory now, and where should we send patients for it?
Are you talking about imaging FFR or invasive FFR?
No, I'm talking about imaging FFR.
No, I mean, right now, FFR is available in every of our every hospital at Emory. So in every place where we do cardiac CT, we have the possibility to send the study to FFR. And we are doing that in all the patients with a moderate stenosis. The indication for FFR is 30 to 90%. And if the study is clean, we don't send it out. Or if it is a clear occlusion or a severe stenosis, we don't send it out. So we are doing that. And if you send a patient in every hospital, they can do it if there are the criteria for doing it.
And how much calcification is too much calcification to be done? There were limits, in the past, I guess.
Yeah, no, you're right. It is in the past there were limits. Right now, I think, and I mean, it's not only me, that there is no really a calcification threshold because in the past, due to technical challenges, a lot of calcification means there was no reason to go on and do a coronary CTA. Right now, even in patients with a lot of calcification, I guess it's worth doing a coronary CTA because you can still get a lot of information, see if the vessel are patent, see through the calcifications. So these days, I don't think we should put a limit in the amount of calcification to do a coronary CTA.
And are renal limits still in place in terms of doing the CTA?
What do you mean? In the renal place?
How bad? Yeah, the renal or how bad a renal situation?
Well, I mean, we use a 35 GFR kind of threshold, but still we can decide to go on with the study if there is the need, if the patient is scheduled for dialysis, if there is a need. So it's a patient-based decision. It's not an overall hard threshold or hard limitation.
Thank you.
And also, to give you another perspective, with the photon counting, all the calcification limitation will be also much less because there are also algorithms able to remove the calcification at all. So there are studies showing that you can remove the calcification just seeing the lumen,
Great.
which is better. Yeah.
I think we're over time, but thank you, Carlo, so much for this fairly robust discussion. It was an amazing talk, and we look forward to all the things that are continuing to come in the future and working with you. Thank you so
Thank
much.
you very much. Thank you again. Have a good day.
Thank you.
The preceding program is copyrighted by Emory University.